Everyone. I'm Lori Robichaud, the Executive Director of La Grua Center, and it's my pleasure to welcome you to our talk tonight as part of our speaker series entitled On Our Minds. La Grua Center's mission is to engage community via arts and culture, and we do so by presenting a wide variety of concerts, art exhibitions, and speakers on a variable range of topics. We are now presenting those events as best we can on digital platforms like tonight's chat on Zoom. We usually start with a little housekeeping. Our program director, Kelly Rusherall, and I are coming to you from our home offices near where La Grua Center is located in Stonington, Connecticut. We welcome your questions, that's what tonight's all about, and ask you to write them in the Q&A feature, and we will get to them after the conversation with our speakers. Further, Kelly will be posting any additional resources that we have in the chat section. But again, please post your questions in the Q&A. Our discussion will be recorded and available on La Grua Center's YouTube channel in the next week or so. And in the next day or so, audience members will get a brief survey that we would love for you to fill out. This is also the time when I take a moment to thank the many people who donate to La Grua Center's annual fund each year. And I know some of you are with us tonight. Those gifts are a very big part of making our year-round programming possible, and they matter now more than ever during the time of COVID when we can't come together in person. So now on to our talk. As I mentioned, the name of the speaker series is On Our Minds, and certainly the COVID vaccine fits the bill. And our speakers' full bios were in your email with the Zoom link. But the shortened version is Marianne O'Hare is the producer of the nationally syndicated health show called Conversations on Healthcare, which is a production of Community Health Center, Inc., based in Middletown. The show was launched to promote a greater understanding of the transformation underway in American healthcare, from the passage of the Affordable Care Act to the current pandemic crisis. The show has welcomed hundreds of influential guests in healthcare, most notably for the purpose of this conversation, Dr. Anthony Fauci, who we've all certainly learned a lot about in the last year. Joining her is Dr. Marwan Haddad, who is the medical director of the Center for Key Populations, which is part of Community Health Center. He's board certified in family medicine and on the faculty of Quinnipiac University. His areas of expertise include HIV/AIDS, hepatitis C, and substance abuse, and now I'm guessing COVID-19. There's so much information flying about regarding vaccines, who's getting them, how to get them, racial inequities in getting them, the new variant strains, how can we hug our family again, and the list goes on. We're delighted to have you both with us tonight to tell us about your work, so welcome. And Marianne, please take it away.
Thank you so much, Lori, and thank you, Kelly, and thank you for the La Grua Center, which I love so much as a neighbor here in Stonington, one of my favorite arts and culture organizations, and I certainly am so pleased to have my colleague Marwan Haddad join me. Hello, Marwan. You may not know, he's about to present next week with the CDC a big, massive presentation, a 3-day seminar that's going to be online with the biggest experts in the world on COVID-19. So you have some very good company here. I'm a messenger. For many years was an entertainment reporter, literally Beatles, Rolling Stones. Now the rock stars of our world, as we all know, are the people on the front lines of healthcare, of science, of research. And among those are Marwan Haddad, a longtime practitioner in HIV/AIDS policy and caregiving, and has been on the front lines of all kinds of breakthrough treatments for medicated assistant opioid addiction and other issues that have been plaguing our society for a long time. And then everything, of course, was co-opted by the pandemic, which a year ago took over the entire world. Because I'm in this position of producing this nationally syndicated show with Anthony Fauci, Paul Offit, Peter Hotez, Michael Osterholm, Lena Wen, names you're seeing across the board right now as spokespeople in this evolving story that's impacting all of our lives. I've been so fortunate to get so much inside information about what's happening, also monitoring the WHO press conferences. And so as I produce this show every week, I have to have up-to-date information. And I feel like I've been carrying this knowledge, and I'm glad that I can share a little bit of it. But I'm not the expert. Marwan is. And Marwan, I'd love to also welcome you to introduce yourself to this audience, because people are asking so many questions. They're asking, why can't I get the vaccine? Where is it? How come so-and-so next door got it and I can't? There are so many questions, so much fear, so much uncertainty. And what you may not know as an audience member right now is that there have been people, including in our organization, Community Health Center, by the way, which is, we should really laud them. They're our organization going into our 50th year of providing healthcare to a large cohort of underserved populations. But we have been partnering with the state of Connecticut since moment one, literally, moment one. And Marwan was one of those state partners, and I'll let him take it from here. But the strategy, the planning, what to do with shutdowns, how to orchestrate that, how to deliver medical care with a shutdown. All these decisions have been going on 24/7, literally, and emails and phone calls and meetings have not stopped since January of last year. And many of you don't see that, and I understand your frustration on your end, and you can vent that when you ask your questions. But I would like to tell you that Marwan is one of those people who has been front and center with the state of Connecticut, using his global health expertise to help guide what we are doing here with the limited control we had over what was happening in the federal government. And now we're in this new phase of vaccine distribution. So obviously a lot of questions. But Marwan, I'd love for you to tell me, first of all, what you do at Community Health Center, what brought you to that organization, and how you're now helping interface with the state and the federal government on vaccines.
Sure. So thank you, Marianne, for the. Sorry, I'm hearing an echo. Are you guys also hearing an echo?
No.
My voice. Okay.
I actually am, Marwan, and I don't know what the difference is because you weren't echoing before. Go ahead and talk some more.
Sure. That seems better now, actually.
There you go.
Excellent. All right. So I do want to say, thank you very much. It's an honor to be here. Thank you for inviting me. I think Marianne was being very humble herself about her own expertise. I've had many conversations with her, and I actually even earlier today said that she could probably give this this presentation today on her own without me being here. But I am very humbled, and thank you for the wonderful introduction. So I am a family physician, as was said, but I'm the medical director of the Center for Key Populations at Community Health Center, Inc. And so Community Health Center, Inc. is a federally qualified health center. It's a statewide health center. We've got 15 health center sites throughout the state of Connecticut. And what we do at the Center for Key Populations is really we focus on those key populations that have had health disparities secondary to stigma and discrimination. And so what I have tried to do as the head of the what we call CKP at CHC is to ensure that there is integration of specialty care as part of primary care for a lot of these populations that do suffer health disparities. So, for instance, when we look at people who use drugs, when we look at the LGBT population, the homeless population, all of them, a lot of conditions and circumstances that they deal with really intersect. And so, under the purview of the Center for Key Populations, we have our HIV program, we have our hepatitis C program, we have our substance use disorder and medication-assisted treatment, particularly focusing on the opioid crisis. We have our healthcare for the homeless programs. We also have a farm workers program. We've got outreach for young parents. So as you can see, we try to really ensure that the underserved really try to get the healthcare that they are deserving and try to reach that equity within CHC and across the state of Connecticut. And what brought me down here, so many years ago I came down for love. I moved, I was up in Canada, but when I did move down from Canada, which has universal health care, I really wanted to work in an environment that healthcare is a right, not a privilege. And as our CHC motto, hopefully you will know, is exactly that. And so I found my home at CHC.
So Marwan, this whole thing unfolded a year ago. The whole world was thrown into chaos. I was, as a journalist, was watching the WHO press conferences in February, and I'm like, it's coming here. Why are they not talking about it? Why are we not preparing for this in a grander fashion? And was concerned then, but I'm just a journalist. I'm not an expert. And what I find interesting is that now, here we are a year later, one of the highest death tolls in the world per capita, and which is so unfortunate. But let's talk first about what happened when you and our organization joined the state, joined other health organizations around the country, not just federally qualified health centers, but every health delivery system had to brace for this. We didn't know what was coming. So tell us about that process of going into this this pandemic before it was even called a pandemic, which certainly has now shown its power. Tell me what that preparation was like as we went in to these shutdowns and experiences that have affected everybody's lives.
Yeah, no, I think in many ways, as we sort of saw this unfold, it was all, I want to say it was almost like a Stephen King novel, right? So you sort of see that there's a premonition of something happening, and it's coming, and day 1, day 30, and so we saw it unfold, and I think we had to make a decision as a health center. Because a lot of times the healthcare that we deliver is very individualized, right? And that tends to be a focus that is very different than when we look at it from a public health perspective. And I think as an organization, and our CEO and senior VP, Mark Masselli and Margaret Flinter, they really sort of made that decision to say, we are now going to venture into helping the state, if we can, do whatever we can to be able to sort of get ahead of this public health crisis. And I think that was quite amazing that we were able to sort of step up and work with the state first to start to set up testing. Right, I think the first part of any of trying to get ahead of any pandemic is to really, you need to identify who is being infected, and you can't do that without testing. And we all know what may have happened at the beginning in terms of the hiccups that sort of occurred in terms of setting up the testing to start out with. But once that sort of got ironed out, we were able to really push up our testing. And I think now we just passed 500,000 tests that we just did at Community Health Center. And so you can imagine that lift that was required to stand up all these testing sites across the board. As Marianne said, I think we were meeting as an organization 3 or 4 times a day, well into the evenings, on the weekends, to try to really figure out how we can help get ahead of this by first identifying people who are infected and try to sort of mitigate through preventative measures the transmission of this virus. And because we were able to set that up, right, it was almost a natural transition, although we're not really transitioning from testing, but a transitional addition, if you will, to add on the vaccination, right, to pick up and start the vaccination administration across the state.
I think the state has to be really commended here, because I think not every state stepped up the way Connecticut did in terms of facilitating, demanding that free drive-through testing be made available across the state. We're fortunate we have an infrastructure that allows for that, and a talent pool that's just so committed to helping people, not just delivering care or making money in healthcare. I mean, and not that that's the motivation, but we had an infrastructure that was adaptable. And we, as you said, they've tested over 500,000 people. And by the way, and here we are in February of 2021, where testing is kind of more important now than ever, because we have only 10% of the people are vaccinated right now, and this will bring us to vaccinations. But just a message to give to you and your families. I know you want to hug your loved ones, your grandchildren, your neighbors. You want to have parties. The testing right now is so important, because the new variants that are coming in are far more transmissible, and we've all gotten complacent, and not everybody has gotten a vaccine. So it's really important to drive home the message that this free testing is still available, because it's going to be the bridge that gets us over to everybody being vaccinated. So let's talk about vaccination. You've been also consulting. You're on a team with the state of Connecticut to address vaccination. When I was doing the show last June, July, August, and they were talking about these vaccines that were in phase 3 trials, including Pfizer right here in our neighborhood. These mRNA vaccines, what were they? This alleged new technology, which has actually been around for quite some time, there was just never the impetus or the financial infrastructure to push this research forward so quickly. But it's pretty clear science, and it always was clear science. Dr. Anthony Fauci at the NIH has been overseeing the pre-Moderna vaccine. He's been working on mRNA vaccines for quite some time. So it's not like there's not a lot of science around it. It's just we're all hearing about it for the first time. It's being called a new vaccine. So if you could help us understand, like, what do you tell your patients, Marwan, and the people that you're out there vaccinating people every day? Tell us what you feel confident about in your understanding of the science.
Sure. So the messenger RNA vaccine is a new technology being used for vaccines overall, but it's not new technology in general. This is something that's been in the works for a very long time, and the COVID pandemic, I think, just allowed lots of funding and resources to get poured in for it to be sort of focused on this. And mind you, we're talking about the messenger RNA vaccines right now with Moderna and Pfizer, but the other vaccines that are coming down the pike do not necessarily use that particular technology, right? So there are many different ways that vaccines can be developed. The initial shock was that, initially we were saying, oh, it's going to take 2 years at least to do a vaccine. Then all of a sudden it seemed like a quick turnaround, and we're saying in 7 months, 8 months, 9 months, we're going to have a vaccine. And then, and then the Trump administration called its vaccine, Operation Warp Speed, which then further, said, wait a minute, why are we speeding through this? Are we cutting corners? What's going on with this, right? And so I think there was a lot of hesitation around the science and our messaging overall when we started out with the pandemic, and where we sort of ended up when it developed the vaccine. So initially, I think we need to sort of keep in mind that the coronavirus is not a new virus. There have been coronaviruses around for a very long time. And so the coronavirus, right, I think we all know it's a common cold. There's many different sort of varieties of the coronavirus. In 2002, 2003, I don't know if people remember the big first SARS outbreak that, sort of occurred. I was in Toronto at the time, and I think Toronto was one of the first North American sort of places where the outbreak occurred for the first SARS. So a lot of work started to sort of be done on the SARS-CoV, this is now CoV-2, if you want to call it CoV-1, started from back then, right? So this is not something new. The full genome of the slightly different new virus, the SARS-CoV-2, was posted as of January 1st of last year by the Chinese. And so we had access to the full genome from the get-go. And I think Moderna, the NIH, had figured out the vaccine, the messenger RNA, within the first few weeks in January. So when
4 days.
4 days, right? Exactly. So it happened very quick because we had the technology, we had the knowledge, we knew exactly what to target, right? It was easy enough. So we knew that we could target the spike protein that you've probably heard about. And so all we needed to do was figure out how to get the spike protein to present itself in our bodies for the vaccine, for us to build that antibody response to it, to be able to prevent, hopefully, infection or severe disease in us when we come in contact with COVID. All right. And so having done that, and we've had done some phase 1 trials already on this, with the amount of resources, we were able to combine phase 1 and 2 trials. So some of the phasing didn't happen sequentially because we were able to do it simultaneously, and we were able to get to the phase 3 trials fairly quickly. And with vaccine trials, it takes a couple of months really in terms of follow-up for us to really get a good sense of its safety, since most of the responses or the reactions that are going to occur to the vaccines occur within the first couple of months, if not the first few weeks after the vaccine. Long sort of, effects can occur. It's rare. And those are things that we're continuing to sort of monitor, which is why we don't have an FDA approval yet, right? We've got a authorization for emergency use with these vaccines, since it was declared effective and it was safe. But for the full approval, we need the full sort of questions that they have to answer for the FDA to be able to get that.
And Marwan, I would jump in here, and one of the treasure troves that I have of knowledge that I'm immersed in all day is every week there's an expert with a different point of view, but they've all concurred. Dr. Alejandro, his last name, I don't want to mispronounce it. He's head of SAGE, which is the organization that recommends vaccine approval to the WHO, the World Health Organization, big rock star in his space. Dr. Paul Offit, who created the rotavirus vaccine or developed it with a team over 20 years. All of the scientists across the international spectrum, now that they've been empowered to share their science, are sharing their science.
Exactly.
There's a manifest destiny here. There's a collective will and a collective purpose with the global scientific community to share their data, share their science, things that were absolutely excruciatingly proprietary because research was so long, so laborious, and so expensive. We have a global crisis. It's pushed this whole. It's opened up this door to a collaborative scientific opportunity that's just remarkable. And for anybody in the audience right now who's thinking, yeah, but it's still so new, and now we got these variants, whatever. The bottom line is, if you have the great preponderance of the scientists of the world who have been dwelling in this space for decades, many decades, and collectively, selectively sharing their information, are now collectively sharing it all together, what we have is a scientific opportunity to move global health forward. This is not going to be the last pandemic. It's not going to be the last iteration of this pandemic. We already see the variants coming in, making some of the vaccines perhaps less effective. So we'll get into that in a moment. But I think it's really important that that those toiling in the medical delivery trenches, who are also researchers and scientists at heart, you don't want to give your patient something you don't feel confident giving them. That's the bottom line. You're not going to do it. And I would caution everyone to stop and think. And again, there are a lot of unknowns, but one of the great unknowns we don't have yet about coronavirus is how truly devastating this disease is, and how it destroys organs. And it literally. We had a guest on the show. I urge you to go to chcradio.com. Dr. William Hasseltine was a longtime Harvard, started the HIV research lab at Harvard and also the cancer research lab there, and then went off on his own and is working a lot in genomics. Basically said, this is a tricky virus. It's a shapeshifter. And what's happening with these organ failures right now is that they are a result of the virus invading the vascular, not just cardiovascular, but the vascular system. So that's why it can go and destroy a lung, or make your brain do funny things, or literally make your lungs look like you've been smoking for 50 years. It does devastation to organs indiscriminately in people that it affects worst of all. And then we're trying to manage them medically with things like intubation and all these other reactive measures. So there's a lot we don't know about the disease yet, but we do know how to interrupt the mRNA, the protein, the spike protein, that little thing that sticks into your cell and finds a way to make a home in your cell so it can replicate itself. If we can stop that, we can stop the mass spread of the disease, and we can actually inhibit what will continue to be variants of the disease. So that's something that the scientists are still working out. But 201, Marwan, wouldn't you say? There's no question. If we don't do mass vaccination right now, and I would ask you quickly, there's a lot of vaccine nationalism going on. We're a wealthy country. We had a slow start getting production up and running, but a guest that I'm editing the show tonight, Dr. Craig Spencer, who survived Ebola as a Doctors Without Borders doctor, and he's based in New York. He said, this is not a give it to me first. If we don't stop that spread of the disease in vulnerable communities, in our communities, as well as around the world, the virus will continue to mutate. It will replicate and mutate. It will pop up again like It'll keep popping up until we get that vaccination globally going. But I would ask you, Marwan, I mean, we live here in Connecticut. We're a pretty diverse state for a small state. You've been on the state level distribution discussions for some time. And we are on the front lines of distributing at our organization, the drive-throughs that we're setting up around the state. Tell us what that distribution discussion is looking like now in Connecticut.
Sure. I mean, so the issues of allocation, unfortunately, really comes from the fact that we don't have enough vaccine supply, right? And so that's where we start off problematically. And so hopefully that supply issue will get taken care of soon in the next few months. We keep hearing that maybe we'll not have a supply issue as much. But if we didn't have a supply issue, everybody would be getting it. We'd be sort of doing it across the board without really these phasings of 1 and 1A and 1B and the subphases within the 1B. But the fact that we were concerned about the supply, we really needed to sort of hone in on two different groups, right? The first group is who is getting it the most and dying from it, right? And then who are the ones that are spreading it? And those don't always come together very well, right? So I think there was a lot of dilemma around how do we do this, a lot of modeling that went into who should get vaccinated first and so on and so forth. And you know, the CDC came up with their own allocations. And what we quickly saw that each of the states independently started to revise and come up with their own phasings as well, which is why from state to state, you see the different phasings across the board. I think everybody agreed. First off, let's get all the healthcare workers who are on the front lines vaccinated. They're the ones that are putting themselves at risk, and that's sort of good to sort of start out with. Then it became fairly clear as well that the majority of the deaths were occurring in 75-year-olds and above. And so, of course, we targeted the nursing facilities where many of the deaths were happening, but also the age group of 75 plus. Then it starts to get a little bit more controversial as to who do we go to next in terms of trying to stop that spread that we're talking about, but also stop the deaths that are occurring. So we in Connecticut and the allocation subcommittee felt that we needed to sort of put the 65 plus, those with comorbidities, those in congregate settings, as well as frontline essential workers, all in phase 1B. But even within that, they started to sub-phase it because of the concern of the supplies. And so currently we're at, as I think everybody knows, last week, I believe, that we went to 65 plus for that. But we're hoping that very quickly, we're going to start to open up those phases a little bit more to be able to give access to more people. Because what we're seeing, and I think we're seeing it nationally, and we're definitely seeing it in Connecticut, that there is this disparity of who is eventually getting these vaccines for various reasons, right? There's access issues, there's socioeconomic issues that may sort of play into that, there's hesitancy issues that may play into that, but we are finding, obviously, that the communities of color who tended to be more vulnerable at younger ages were not getting to the vaccines as often and as the white population in Connecticut and across the nation. And so I think we're trying to focus a little bit more on the equity issue of how do we get it to those individuals who are still at high risk of dying more so than others. And at the same time, trying to address this hesitancy issue of what we're sort of talking about today, right now, right? We're talking about the potential mistrust in not only the medical community, perhaps, especially when it comes from communities of color, but really sort of looking at for hundreds of years of abuse that they've endured, but also really looking at ensuring that we're getting the vaccines to those people who are also going to sort of spread it, right? And so that is the focus that we're looking at now in terms of the distribution and the administration. So I think, we've done a great job at setting up these mass clinics. And I think, CHC has set up the largest mass clinic in Connecticut. It's the 10-lane Pratt & Whitney, sort of it's an impressive village, I think we called it, a vaccine village up there.
Vaccine village,
for it, and that was done in a few days. But we also quickly sort of realized, as all the people coming through, that there wasn't much diversity in the people who were vaccinating who were coming through, and that was issues of access to the internet to sign up on the VAM system, which I think all of us have been very frustrated with. The trying to get the appointments in. DPH did a great job of setting up the 211 call, so that way if you don't have access to the internet, call 211 and get in there. But also there's transportation issues, right? We're not in the local communities, and so to be able to get out to East Hartford would be fairly difficult for many people who are very vulnerable. And so then, in addition to the mass clinics, we also have to start to focus, and which we continue to focus on, smaller clinics that we go out into the community, to our homeless shelters, to congregate settings, to be able to get to the smaller numbers of individuals who can't make it to us as well.
So one thing I would like to, because we've been going for about a half an hour now, and I'd like to bring up a point, and I think this is something that everybody's been talking about, which is, where'd you get your appointment? The Stonington Forum is like, somebody mentioned somebody, if you call this number, you're going to get through. And I get it's there's not enough supply for the demand right now. And that's the biggest issue. I think the broader and grander issues of health disparities in American healthcare and healthcare around the world, frankly, is being manifested significantly by this pandemic, because people of color are dying at dramatically higher rates,
right,
and they're gaining access to necessary healthcare in lower numbers as well. And now the vaccine is another example of that. So those are big issues. Those are not issues we can figure out overnight. Or as one of my recent guests from Johns Hopkins, Dr. Monica Shark-Spana said, it's not just 2 jabs in the arm that are going to fix this issue. But right now, we all want one, right? We all want that vaccine. We want that jab in the arm. We're trying to figure out how to get it. We're kind of climbing all over each other to get that appointment. So I'm curious what the audience is thinking right now, because everyone has a unique experience to their own personal worldview. And you brought up a very interesting point, especially with the 75 and older crowd. There just were simply a lot of people in that age group, motivated or not, who did not have access to the technology required to make the appointment. So a lot of people we saw coming through our lines in East Hartford are people whose daughters or daughter-in-law or neighbor helped them get signed up for their appointment. And they're coming through. I can tell you, I don't know if you guys have had your experience yet having a shot, but people are bringing flowers to our practitioners. They're just so overjoyed they're getting their shot, and they're excited that they feel like they're one step closer to this sort of chimera, which this concept of herd immunity is very unfortunately hackneyed, because this is one really important statistic that you should understand. This quest for quote unquote herd immunity. Let everybody get infected, no problem. That'll be the vaccines are so effective. The data is dramatic. I mean, it's not even just a little bit anecdotal, it's dramatic. The vaccine confers to the person, by orders of magnitude, much higher levels of protection against further infection. It's just a fact. It's a scientific fact. It's data driven. So it's more consistent, right? Yeah.
So we know that natural immunity, when you do get infected, the natural immunity can vary from person to person in terms of the amount of response that you sort of get within your own body. And so we generally say that if you get infected, for the most part, you're 90 days protected. Beyond that, maybe for some, for sure. For others, maybe not as much. We hope it's longer, but we're not sure. But we've also seen small cases, but chances of people getting reinfected even under the 90 days. And so it really varies. The vaccine, because it is as Marianne said, it is so targeted to the immune system, and it's so potent in terms of the response it elicits from our bodies, that the threshold, especially with Moderna and Pfizer, but even the newer vaccines that are coming down the pike, Johnson & Johnson, that is sort of likely going to be approved for emergency use in a couple of weeks, and then AstraZeneca eventually, all of them really create a threshold of antibody response that is a lot more consistent, which is why we're saying, even if you've had COVID, you might not need to sort of get vaccinated immediately within the 90 days of you getting it, but at some point you should get it because it will ensure that you're getting that prolonged sort of response as much as we know so far from the vaccines, if that makes sense.
It does, and thank you so much for that, because there's a lot of clarifying going on across an ever evolving landscape. I know that Lori has been taking some questions from people, and Lori, I'd be happy to have Marwan answer any questions from the audience right now, because I'm sure you guys have a lot of questions.
So, I see a few questions on here I just pulled up in the Q&A, and I think a lot of them were around, if you get vaccinated, what can you do for the most part? How does that change your life? So I think let's just touch upon first, what do we know for sure that the vaccines protect you against? Okay, so most of the studies looked at at how symptomatic do you get from COVID if you get the vaccine? All right, and that's a very specific question. So what we do know is that Moderna and Pfizer right now confer 94 to 95% effectiveness from stopping you from getting sick from COVID. All right, they can't say, and it's much easier for us to say, you won't get infected from COVID altogether. That question is still out there. We think it may be that you won't get infected as well, but they did not test for asymptomatic infection. All right, so I hope that that's clear. So the best that we can say is if you get vaccinated, you will not get sick from COVID, 95% of the time with Moderna and Pfizer. What we can say is every single vaccine, and I think you're going to be hearing different effectiveness from Johnson & Johnson, AstraZeneca, that might start to cause more questions of equity. And we're really comparing apples and oranges here. And we can talk about that at a later date if you want, or now if you're interested. But just to answer this, in terms of what we have in terms of Moderna and Pfizer, you are protected, like I said, sort of 94% of the time, but all of the trial. If in the vaccine arms, nobody got hospitalized and nobody died, right? So this is the most important message that we need to get out, that in all these vaccine trials, hospitalizations and deaths, as far as we know, were 100% avoided and prevented in those who received the vaccine. And so I think that first should be clear. So the question then is, why are we still saying if you got vaccinated, why should you still need to wear the masks, keep 6 feet apart, and hand wash and all that? Is just because of that point, that we don't know whether it prevents asymptomatic infection. And therefore, if you are asymptomatically infected, you can probably still transmit the virus. And now with these new variants as well, until we know a little bit more about how these variants are going to be sort of working at, I think the messaging is still going to be, please, even though you're fully vaccinated, you're less likely to yourself get infected and get sick from it. But we don't know yet about the asymptomatic infections and transmissions. So please continue to be careful of the transmission issue.
The public health measures are literally more important now than ever, because there's somebody in this group raises a really interesting question, which is, if my husband and I have been vaccinated, can we have dinner with our grandkids? Who haven't been vaccinated? And a couple things there. We still don't know how widespread the variant is. We believe, many scientists that I have spoken to who know what they're talking about believe that there will be another surge. They're going to call it the fourth surge because of this very question. Families are going to feel a little more comfortable because some of them have been vaccinated, others have not. There's a push to get kids back into schools and back into activities for every logical, legitimate, spiritual, social, psychological reason you can imagine. The kids need to be in school, but not if it's at the risk of everyone's health. And the question is, whose health? You just don't know. If you're in a group where just 2 of the 10, even though they're family members, are vaccinated, masks, social distancing, even taking masks off at a dinner table is risky. It all of a sudden, it elevates your risk by orders of magnitude because you don't know where those kids have been during the day. You don't know where your spouse, a co-worker of spouse might be. So, and again, there's this risk factor of COVID that's become so tricky, and why it's such a Rubik's Cube is there is this asymptomatic period where you're almost more likely to spread the virus, where the virus count is actually much higher before you're symptomatic. And some people never become symptomatic, but it could infect 100 people. So that's the question mark. And right now is a very, very tricky time because as the vaccinations increase and continue, and more people in the community are protected, that risk goes down exponentially.
I feel like a lot of the questions that are coming in are sort of asking us, I'm going to be like a therapist. I'm not going to tell you what to do. I'm going to help guide you to make your own decisions as to what you are willing and not willing to do based on your own risk aversion, if that makes sense, right? I think we learned a lot from the HIV epidemic. And I think, there are such parallel, there are so many parallels that you can draw between the two epidemics. But the one I would sort of say about this is when it comes to infectious diseases and transmission, right? You're going to have to figure out what it is that you feel comfortable doing and what you feel not comfortable doing, and then possibly sort of sticking to that as best as you can, right? And so when you and your husband, you're both vaccinated, you're doing well, and you're still part of the small little inner circle, and you want to see your grandkids, it's up to you to decide. Sure, I'll see my grandkids, knowing full well that the percentage risk, right, may be lower, but it's still there, about potentially getting a variant. We still don't know anything about that. There's more coming on. Getting a variant that may not respond as well to the vaccine. So far, it looks like they do, but coronaviruses, like any other viruses, will continue to mutate as long as they continue to replicate and transmit in the population. So that's why we need to vaccinate as many people as we can, as fast as we can, to stop that replication process, to slow down the mutations from occurring. Right.
Well, and Dr. Fauci also spoke very, very eloquently to this, and he repeats it. He didn't see his own family at Christmas. He did not risk that. He got vaccinated eventually, but he's wearing double masks wherever he goes now, right, even though he has protection.
So I would say, I know it's like you see the light at the end of the tunnel. We're almost there, but there's new stuff happening. We're going to be living with COVID for a while, but I think right now is a critical time because we're starting to ramp up the vaccinations. We're not where we need to be in terms of the number of people getting vaccinated, and we're starting to see these variants show themselves, and we don't yet know how they're going to behave very well, right? And so I think just hang in there for another month or so or two until we know a little bit more, and then you can sort of make more decisions on your front, right? In terms of that. I hope that helps a little bit in terms of your thinking. I know right now, as soon as the vaccine started going on, I know we're like, okay, where can I travel to next? Let's sort of look up and where can I go travel because we haven't traveled in a year, or who can we go see? Just take a deep breath, think about it, just prolong a little bit more until we know a little bit more. We vaccinate a little bit more people, and then hopefully we'll know, what we can and can't do with more certainty in the coming months.
One of our followers, one of our viewers tonight, is asking a really important question. And parents, I don't know how parents have dealt with this. I honestly don't know. One mom, son had cold symptoms. She went for a test. It took 5 days to get a result. I can say that our drive-through free testing right now, which is babies to 150 years old, wherever you are in that spectrum. And we have a pretty swift turnaround. I think it's 18, 2 days,
48 hours.
18 to 20, yeah, right, 18 to 28 hours. So they've gotten the testing infrastructure up to meet the demand. So mom, if you have any questions, please privately email me. I'd be happy to help you out with that. But that brings up a very important question, which is this push to put kids back in school. Some kids are hybrid, some kids aren't. If my kid has a cold, which is a very typical thing to happen in any winter, by the way, flu is down to almost 0 this year, which is remarkable, which says something about public health interventions being a way to stop the spread of illness. But, and it also shows you how much more infectious COVID is compared to flu when you see those numbers. But a cold, you're right, Mom, the kids get colds. And that is a really tough question. And you are a family. What would you say?
So what I would say is, obviously 5 days, 7 days sometimes. You're right. Ideally, we'd want to test that you get the results immediately, so that way you can sort of act upon them and figure out what you need to be doing. Keeping in mind that there's false positives, false negatives, always with any test that we do. We got it down to 2 days, and so 2 days is not too bad. But I would say that it looks like, for instance, in your case, your son works in an elementary school. He might be a teacher or works there. But the issue with that is the many of the schools, at least we know in Middletown, they could have these rapid tests that you get almost immediately. Those are not PCR tests. They tend to be antigen tests, which tend to be a little bit less accurate. However, if you're symptomatic, they're not too bad. So if you're asymptomatic, many of these sort of point of care antigen tests are not too good, and we don't advise people to use them. But if you do develop symptoms, doing that test to get the immediate test might give you a little bit of a more immediate answer to be able to act upon if you have access to that. And I believe, at least in Middletown, I know that we've set up a lot of these rapid tests, especially for teachers to be able to test themselves when they become symptomatic.
And I think it brings up another really interesting point. Community Health Center, which we have, we're in over 100 school-based health clinics. So again, we have an infrastructure based within the school system. These school systems that have partnerships with health entities that can facilitate this partnership of something as important as testing. If you're going to put all those kids back into a building and all those teachers, testing is so absolutely fundamentally imperative to that reality, and it needs to be decision one for how school systems decide to do that. Because if you can't have really highly functioning, readily available to everybody involved testing, then you just don't know. You don't know where the cases could sneak in. I also think it's important to understand that the Biden administration has kind of heard that call. There are a lot of scientists that have been calling for these rapid tests to be like a cheap at-home dipstick test that you do before you leave the house. And if you're going to go to the office or school, you just know within 15 minutes you get a response. You're going to see some movement in that in the next few months, where that's going to become part of this public health paradigm that's going to help empower all of us. Because a lot of us, just everybody, even those of us who are in the industry, have questions about how to keep ourselves and our families safe. And, you know, our job at community health centers is to keep our patients safe as well. So we have taken this to another level. But you're going to start to see more. I don't know how. I mean, it's in rapid development. The deployment is always a question. I think right now there's such a hyper focus, for good reasons, on vaccines and getting them out. And if anybody in this audience has been to one of our drive-through vaccine sites already, you see how easy it is. You don't leave your car. Well, the difficult part is getting into the system. That's going to get better too. We promise you. It's going to take some time. But then you literally drive through. You're in the system. We have the National Guard partnering with us, right? Mm-hmm. Tell us what it's like in those drive-through vaccine sites, Marwan.
You know, it's incredible. I was out there, I think, earlier this week on a day where we had probably around 2,000 patients signed up to go through that one day. And, you know, when I drove in, I was doing the afternoon shift and seeing the line of cars all in 10 lanes, all the way back, with the National Guard helping, you know, sort of, you know, traffic sort of, you know, control and those cones that are set up. I mean, it's like a runway. It's truly impressive. You know, the wait was long. People were very gracious. Well, let's say most of the people were very gracious, and those who were not, was very understandable in terms of how long people had to wait to get it. But again, I think the fact that people are able to sign up, that we're getting people through, and that, you know, for the most part, we got everybody vaccinated that came up and gone through within a couple of hours was just. Was an accomplishment, despite the fact that some people did have long wait times there. So I would just sort of say, please be patient. Know that we're working very hard to try to get the vaccine to everybody as fast as we can, and we'll continue to sort of try to improve on our performances as we learn day to day from that. I do want to address, because I see a question, and sort of Sharon, we haven't really addressed it so much. So Sharon is asking about, in November, you know, renting out a beach house and a group of women are coming together, but one doesn't want to get vaccinated. How do you navigate that situation? I would say between now and November, a lot of things can happen, and we might learn a lot of things as well. So, from the fact of, would we know by then that if you get the vaccine, you won't be able to transmit it, and so that in some ways that's good, and so that might sort of clear your concerns from that one individual who didn't get vaccinated. If she comes down with it, then you guys are all protected. That's great. We'll know a little bit more about the variants and whether these vaccines are protective against all variants or not. They're going to also, we'll also probably know whether we're going to need boosters, right? Is this vaccine going to become a booster vaccine that we do like the flu shot every year, and just figuring out genomic testing, which variant is around. And what's great about these messenger RNA vaccines and the other vaccines is you can manipulate them very quickly, very easily, and get them out to production very quick. And so already, I think the manufacturers are starting to work on that. So it might be that in September, we need to do a booster, and maybe not. So I think if you're not going to lose any money, you'll get fully reimbursed between now and November, rent it, keep talking about it, keep educating each other about it. Hopefully the individual will get the vaccine if they get convinced or if they can, and then make a decision when it's closer time to get to that beach house, which sounds lovely, by the way.
And I heard a very interesting story on NPR today that like the wedding industry is cautiously a little bit more optimistic about 2021 than last year. And just that people are feeling like they can plan a slightly bigger wedding than just the immediate family. And, there is this, as the vaccine starts to infiltrate and spread through our communities, you are going to feel the sense of relief, like protected. There's a protection around. But Marwan is cautiously optimistic, but also keeping an eye on the data and the science. And somebody's asking a question right now, which is, what data are most important? Is it the infection rate? Is it the hospitalization rate? Is it the death rate? And one thing we do know is that the death statistic lags infection by about 3 weeks. So what is your answer to that, Marwan?
I think it depends upon what question you're looking at and what problem you're facing, right? Mm-hmm. So if it's, just to take, like, if it's like Ebola, right, where people get it and they die very quickly from the Ebola, then hospitalization is not an issue because you're not going to get these bodies in the hospitals and the ICUs lasting a very long time, right? But with COVID in general, you get hospitalized, you're in for a very long time for many people, you're in the ICUs, you're using up the ventilators, and then many are dying. Then all of a sudden, what's important is, what is our hospital capacity and our ICU capacities, and how much are we avoiding by hospitalizing and treating? Are we avoiding deaths or not, right? So I think ultimately we want to avoid deaths. We want to avoid hospitalizations and sort of the capacity and not reaching capacity because that's how things are going to get even worse. But then, so I think both those are extremely important, and especially based on what your capacity is like in your communities around that. So one, you want to decrease deaths, absolutely, and you want to make sure that we don't overwhelm hospitalizations. But that doesn't mean that we don't care about infection rates either, because as Marianne sort of pointed out earlier on, we are starting to learn just a bit, and we're learning that there's so much more things going on in the body secondary to the COVID infection for some. As you've probably heard about the long haul COVID syndrome, the post-COVID recovery, and the symptoms that are persisting for a very long time. And whether it's the brain fog, neurological, whether it's lungs, whether it's heart. So we know that there is morbidity that is going to be linked to this COVID virus. And so stopping infection rates and how much that's going to cause that morbidity, that problems that are ongoing for all the people, right, who get infected, is also something we would like to ensure that we keep low, right? Because also, what happens to their productivity? So if you've got a 40-year-old who can no longer work because they're having breathing problems or heart problems or brain fog or neurological, then all of a sudden we're starting to also affect our society, our families, our communities, our society, our jobs, our employment, and so on.
So on that note, a recent guest we had on the show, Dr. William Haseltine, and I recommend that you go to his website, William, Haseltine. Again, the Harvard researcher I talked about earlier. he said that, and this is a statistic that we're seeing now more and more, which is for every one positive that we register through our testing, which is not fully adequate still because it's just not widespread enough, there are probably 10 other additional infections. So while the numbers are coming down right now, they're coming down off the worst high we've had since the pandemic began, as a result of all the Thanksgiving travel and Christmas people, families thinking, oh, we'll just get together with a few close friends. We've seen the results of that, unfortunately. So it's really important to understand that looking at the infection rates are really important as a predictor of what could come next. And what they learned in places like England, which was, where the UK variant obviously came from. And also, if you looked at the data across South Africa and Brazil, that rather quickly, the most virulent strain of coronavirus were these new variants, and they had become more infectious. They had become more opportunistic. They had survived in the population long enough because they were trying to do some little herd immunity in some places where all it did was just opportunistically replicate itself. And unfortunately, that's where the variants come from. So there's a lot we don't know from now until, let's say, late May, June, when we see much more widespread vaccination. We urge you to proceed with caution. We hope you do.
And sorry, let me just say one thing, because I don't want us to think about mutations as coming from elsewhere and causing problems.
Right, they're here.
Right? The mutations will always occur. It just, they called it UK and South Africa because they identified genomically that that's where it was. But we're going to get our own California, Connecticut variants, the US variants. We're going to see it. That's what viruses are going to do. And the only way to stop these mutations and the variants is by getting ahead of it, decreasing the replication, decreasing the transmission, by getting vaccinated, by doing the preventative measures of masking and distancing and hand washing and all that we've been talking about.
Yeah.
Well, you've seen my face pop on, but thank you. I think you actually gave us very good conclusionary remarks that there is light at the end of the tunnel, but we still have to remain vigilant, and the vaccines are wonderful. And I'm not 65 yet. This is like the one time in my life I wish I were. But I'll be in line. But I know we're moving in the right direction. And of course, I'm speaking on behalf of a facility that can hold 150 people packed in, which is a less charming thing to think about it than it was a year ago. So, we're all very eager to bring people back into our spaces, but we want to do it safely. And we've been on talks with the head of Yale's School of Public Health, who's offered the cultural arts community a lot of good advice around ventilation and the things that we have to consider. And we're trying, which is why we're on Zoom, because even with 6-foot distancing, we could probably get maybe 28 people in our space, but we don't have great ventilation during the winter months. We're looking, we purchased screens, and we're going to do some outdoor concerts, we hope, this summer. So that's where we're sitting. So we've come to our hour. Thank you both so much, Marianne and Marwan, for helping us wade through. It's a fascinating topic. Clearly, it's timely and changing every damn day. So we really appreciate you being here, and to our audience for tuning in. Again, we'll send out a quick little survey to our audience members, so be on the look for that. And everyone, as we say, stay safe, stay positive, and test negative, I think is what
Wonderful.
Thank you again, both of you, and good night.
Thank you. Good night.
Thank you. Thank you.